All right. So welcome to Medical Grand Rounds. There's a few folks in the room, but we do have an exciting announcement for those who remember from the past. We are going to have Classroom D back. Sorry? Starting in February. Just for those that are used to coming to Clinical Sciences Building, please just make a note. Starting February, we will be in Classroom D. And I do believe the first one will be the Medical Jeopardy rounds or something. Okay, maybe. Regardless, we're still looking for contestants for Medical Jeopardy, I was asked to mention. So we'll go ahead and get started today. Before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. I'm delighted to introduce our guests today. So I'll start off with Dr. Tali Mogus. Dr. Mogus has worked with people with substance use disorders, complex chronic diseases, and multiple social vulnerabilities since finishing residency in 2009 in both Calgary and Edmonton. She currently works at Radius Community Health and Healing, formerly called Boyle Macaulay, in downtown Edmonton, and has been there for 12 years. She also works with the Addiction Recovery and Community Health, or ARCH team, at the Royal Alec Hospital, providing addiction consultant expertise to inpatients there since 2016. Dr. Kirkwood has been a family physician in Edmonton's inner city since 2012, providing primary care to patients that are unhoused and experience mental illness and substance use disorders at Radius Community Health and Healing. As an associate professor with the University of Alberta, she's very passionate about helping educate primary care providers and learners to care for marginalized patients in a way that is empathic as well as evidence-based. She attended medical school and residency at the University of Alberta, has 2 kids, a fluffy dog, and a very patient partner. So welcome to you both, and thank you for joining us today to talk about the management of inpatients with opioid use disorder.
Thank you so much. Thank you so much for having us. All that is true. My dog is still very fluffy and my partner patient. All right, we've bitten off a lot to chew today, so we're going to get right into it, and we're really, really excited to be here. And I'm going to learn how to advance slides effectively. There we go. All right. Any disclosures, Dr. Mogus?
I have no disclosures.
There you go. And then, yeah, thank you for those introductions to talk about our experience and why we think that we know that we are capable of talking about this topic. So I do have a few disclosures with my work with the university. I do a lot of teaching, and if there is a non-industry funded organization that wants to give me a speaker's honoraria or travel expenses, I will accept it. I do not have any pharma or any industry related conflicts. And I think that's really important because I'm going to be talking about drug choices. And so the only thing that sways my decision is what the patient wants and what's safest for them. I also put on there that I have a bit of correctional experience, not as an inmate. We won't be having confessions today, but as a medical provider, both federally and provincially. All right, so today we're going to be hoping to improve our understanding of opioid use disorder as well as opiate agonist therapy, the treatment for this illness. Dr. Mogus has taken the incredible task of clarifying some very confusing legislation around this topic and also dealing with some specific issues that we see on the wards and with our inpatients. And then I'm going to wrap it up with some discharge planning and some resources. All right. Okay. I'm going to make sure I'm looking at the right screen. Okay, so this is our clinic, and I just thought I'd address something in that I don't have any industry conflict, and neither does our clinic. When we changed our name to Radius, many people thought we were just bought out by pharma, which maybe would make things a lot easier for us as a not-for-profit and not an AHS affiliated organization. Times be tough in the inner city, but we do the best we can. And we just changed our name because everyone thought we were either Bissell or Boyle Street, or many of the pharmacies that were called Boyle. And honestly, our staff are busy enough responding to opioid poisonings outside. They don't need to also be clarifying who we are when we've been working in the inner city for 40 years. So that was the background behind the logo name change, the facelift, though I love that this is still an accurate photo, that we still have our old name on the building, because no one knows who Radius is, including many of our clients. They're like, what is going on? Okay, I'm gonna jump right in, because working at Radius, if you're not aware, our clientele, we specifically take patients who cannot access care elsewhere, and primarily that means that they are unhoused or facing severe poverty, and that they struggle with complex comorbid mental illness and substance use disorders. And so Dr. Mogus and I are very, very familiar with working with patients with opioid use disorder, and then especially on her end as an inpatient through the ARCH team. And so we really wanted to come to start with the basics, to talk about opioid agonist therapy, and then go into more specifics. So these are the main things you're going to see patients with opioid use disorder come in on. Methadone being the classic, the tried and true opioid agonist therapy. Buprenorphine, naloxone, or Suboxone is another effective option that we see many patients on. Extended release buprenorphine is otherwise known as Sublocade. It's a monthly subcutaneous injection. Slow release oral morphine or Cadian, and then injectable hydromorphone or diacetylmorphine. Hydromorphone is what's used here, and that is injectable opiate agonist therapy, or IOD. At Radius, we provide all the top four, and then the fifth is provided through another organization, and Dr. Mogus will tell you a bit more about that. I think what gets confusing about these medications, and I'm going to take us a little bit back to maybe medical school or wherever we first learned about them, is this idea of a full agonist and a partial agonist. And so I stole this example from Christy Sutherland, who's an incredible badass doctor out of BC, who I fully confess I had a crush on the first moment I met her. She, in fact, stole this from a pharmacist she worked with. So this is just passed on. Feel free to steal it, take it with you. But if we consider, we know our full agonist, right? We know our fast cars. I know nothing about cars, so whatever that kind of fast car is, I imagine it can go to 180 kilometers per hour pretty easy. Our full agonists are our fentanyl, our morphine, and our methadone, okay? And we know what it's like to give someone naloxone that's driving down the highway at 180 kilometers per hour. We drop a rock on the hood of their car, boom, that hurts. They stop, right? And the best example we got for that is the little old lady on the ortho ward with rest 4. And when you give her naloxone, she shoots up like Gollum, wide awake, no teeth, 3 hairs flapping in the wind. It's terrifying, right? It's terrifying for everyone involved. Personally, we know it because we used to respond to an opioid poisoning maybe quarterly, maybe monthly, and now it's up to about 15 times a day. In fact, as providers, we no longer respond to those. Our front staff do, and they save lives every day. And we're only brought in if additional measures are necessary, like CPR and things like that. So that's familiar to us. But what is this partial agonist about, this buprenorphine, and why is it complex? Why is it confusing? So while we're not dropping a rock on the hood of a car, if a patient has a full agonist like morphine or methadone on board, and they're driving 180 kilometers per hour, and we introduce a partial agonist, particularly this partial agonist, which has a very high affinity, is very strongly attracted to the receptor, it will remove the full agonist and replace it immediately. And then we're slamming on our brakes. And we're slamming on our brakes to 50, and that still feels pretty yucky. We're going to have a bruise from our seatbelt. Our neck's going to be a bit sore, right? So patients are going to go into what we call precipitated withdrawal. That means that we thought we were doing a good thing. And for many of our patients who get some Suboxone on the street for whatever reason, and they say, hey, I hear this is saving lives, I'm going to try this. They think they're doing the right thing, but they feel very, very sick in that moment, right? So you may hear patients say, oh, I don't really want to try this Suboxone, this buprenorphine, naloxone. I don't want that because it made me feel so sick. And what happened was they had a full agonist in their system. They took this partial agonist and it forced them into withdrawal. And if we think of withdrawal like, well, that's just like, I don't know, like a tummy ache, you're a bit sweaty, you're a bit clammy, it is absolutely not. Because what we see are patients who are in extreme psychological and physical pain every day, desperately searching for analgesia. And then that analgesia is suddenly removed. So it isn't just a bit of diarrhea or a tummy ache or a little bit of sweats. It's severely traumatizing, both physically, but also emotionally. That thing that was keeping us going, that was storing our trauma, was just ripped away, right? And patients experience it all the time when they have access to their analgesia, when they don't. But what we're trying to do is not introduce that horrible feeling ourselves, right? Iatrogenically, we don't want to do that to them. So this table is from the BC Center for Substance Use guideline. It came out in November 2023, and it's a decision support tool where we compare our different therapies. The bar across the top, for the purposes of this talk, we can pretty much ignore, because I don't care if a patient is retained in treatment if I can't even get them started on something, right? But just to understand that when we're talking about systematic reviews and RCT level evidence for opioid agonist therapy, these are the outcomes we get. In the evidence team that I work with peer with the university, we like to say, we don't care what the evidence says, we'll show you the evidence, and you get what you get and you don't get upset. So the outcomes that are in that level of evidence are either retention and treatment or abstinence from street use. And that isn't what I'd like to see. I want to know about mortality, morbidity. I want to know about societal outcomes, but we don't have sole trials against placebo for these things that give us those outcomes, and we don't have comparative. So if you're hearing a lot of like, buprenorphine naloxone is so much safer than methadone, we don't know that. I mean, do we have more people that potentially have an opioid poisoning that had methadone in their system? Yeah. Do we have less that have buprenorphine naloxone in the system? Sure, but we don't have direct comparators. What we do have are studies where we see that opiate agonist therapy, regardless of what of these options it is, saves lives and keeps people alive. But when people leave trials, that is when they have a poisoning event and that is when they die. And that is why withdrawal therapy or starting someone on a treatment to slowly taper them off of it is not a recommended intervention for opiate agonist therapy, because that is potentially fatal to them. What I do care about is how we start this med, and that comes back to those cars. So when we're talking about buprenorphine naloxone, a patient to traditionally start it has to be in some element of withdrawal. And that gets tricky when a patient's in pain, they're here at the hospital, and you say, hey, I really want to help you. How about you get super sick first? Not a lot of people want to do that. And if that's the only option that they're provided with, many people will choose to leave. When we're talking about things like methadone, slow release oral morphine, those do not require people to go into withdrawal. And then the extended release buprenorphine does require a period of stabilization on sublingual buprenorphine, naloxone, or Suboxone before starting it. So if someone has told you that you can just give someone extended release buprenorphine or Sublocade right from methadone or right from fentanyl, they are incorrect. All right. Luckily, we have a tool that we can use to assess whether someone's in enough withdrawal to start buprenorphine naloxone, and that's our clinical opiate withdrawal scale. This contains both subjective and objective symptoms that patients have, and they don't need to be super sick. In fact, my patients, when I tell them to come back in withdrawal, will be far meaner to themselves than I ever would be. It's a moderate score. It's this 13 to 24. And patients know when they feel a bit of withdrawal. And often at this day and age, you could talk to somebody and say, let me know when you feel ready to start buprenorphine naloxone if that is the chosen path. Also, you do not need to have an MD to initiate this scale. You can have any designation you want. You can just be literate and verbal, and you can find out from somebody if they're in enough withdrawal. Dr. Mogus co-authored, and I, behind the scenes, helped the peer team that I work with through the university publish a opioid use disorder for primary care guidelines. So this is one of the visuals that comes in that guideline. It's a 10-page guideline. We commit to making guidelines really, really simple. So though there's much more covered in the BC guideline, if you're looking for a quick primer and a review of our systematic review, you could find that there. I just put this up as this would be one option for an office-based induction or one of those traditional inductions. When a patient gets a dose, they have to see if they tolerated it, if they didn't go into a bit of withdrawal, and then you can proceed with their induction. What you have access to through Connect Care are the ED buprenorphine naloxone initiation orders. And so this is an order set that's located in Connect Care that you here at the U of A have access to. If you click on that link, there's a lot of information for you there, and I encourage you to take a peek to familiarize yourself. And then you can select through your order set how you want to proceed. But again, this is the type of initiation that requires a patient to go into withdrawal first, moderate withdrawal, score of 13 to 24 on the COWS scale. Another option that is really commonly used by the ARCH team is called a microinduction, and this would be an example of a rapid microinduction where we don't need a patient to go into withdrawal. We can give them itty-bitty doses of buprenorphine naloxone, actually taking these tiny tablets and quartering them, and they're very, very tiny. It's kind of, I'm sure the accuracy looks a bit like that there. And so you're giving them little doses, and this is oh, I'm sorry that the slide kind of pushed that over a little bit. You will have access to these slides, but this is the exact order set that ARCH uses when they're starting someone on buprenorphine naloxone directly from a full agonist. And that at about 3-day mark, you will be at a good dose of buprenorphine naloxone. And that didn't require the patient to go into withdrawal. So how do you decide? It's tricky, right? And I think that the main thing is that we are not the ones that are making the decision. We are offering a menu of options to our patient, right? And that is what is tricky here, particularly at the U of A, where you're relying on a virtual consult service when you're trying to make these decisions. And you're dealing with a topic that potentially, if you're of the vintage of myself and Dr. Mogus, wasn't covered really thoroughly in our medical training. It wasn't even really talked about that much. We sought out additional training and experience that made us the expert that we are today. But I know that I've gotten phone calls from providers here that have said, I'm in way over my head and I don't have an ARCH team. And my patient told me that you're their doctor and to just phone you. So is that okay? It is 100% okay. In fact, our main target, our main goal, our not so secret agenda item that I think I blew right past there was that we really, really want you to phone us. And if you see our clinic phone number or our names, I want you to pick up the phone and I want you to phone me before you phone a virtual consult service that has never met my patient. Okay. Also, have a conversation with your patient before picking up the phone to contact that virtual consult service if you can, because your patient has a lot of expertise. They deserve to have at least an MD in opiate use disorder because of the life that they've lived and their experiences. So if you say to them, what has worked for you in the past? Is it Cadian or slow release oral morphine? Is it methadone or is it buprenorphine, naloxone, or Suboxone? They can probably tell you. And if all they hear is we're going to start you on a high dose of buprenorphine naloxone tomorrow, and then we're going to give you Sublocade the next day, again, that's pretty scary. And that might mean that they'd like to leave. And unfortunately, we see that happen more often than we'd like. All right. This is a continuation of the table from the BC guideline that compares a few other things that are of note. One being that there's a higher potential for adverse drug-drug reactions with methadone. So involving your pharmacist on your team is a fantastic idea that I highly recommend to make sure if your patient has chosen methadone as their option of choice, that's one that you're going to make sure is okay to start. The other big one is that QT prolongation, so that you should be doing an ECG before starting methadone, or if a patient comes in on methadone, doing an ECG to check on their QTC. Our watchful QTC is about 500. So if they are above that, if they came in on methadone and we're thinking about lowering their methadone dose because of their QTC, we need to remember that we're emptying their bucket a little bit. They're going to go into opioid withdrawal, and we have lots of options that don't prolong their QT that we can fill that bucket up with. They don't need to just suffer because of that, suffer for safety. That doesn't need to happen. If their QTC is in a watchful zone and we don't think that methadone is an option, again, we have other full agonist options, particularly the slow release oral morphine, that do not have those QT prolonging effects and are a first line therapy for opiate agonist therapy. There was at one time that was a specialist level. That was only if you failed these two. That is not the case. If they cannot or will not go on buprenorphine naloxone, they cannot be on methadone, slow release oral morphine or Cadian is an absolutely fine option for them. And then the last thing I'm going to touch on is what about these missed doses? Patients come in and you find out that they haven't been to their pharmacy for a little bit because maybe they were hobbling around on their osteomyelitis, or maybe they were really, really sick and that's what led them to hospital. So I've just summarized the BC guideline in this table to say what is the number of days that a patient can miss before we have to change their dose. This is where buprenorphine naloxone comes out on top. If they're not using any other opioids, they can have up to 5 days before you need to change anything. If they've missed 5 consecutive days, you can just boom, give them their dose that they had before. That's perfectly fine. If they have been using other opioids, that's where that fast car might have snuck in. The fast car might have attached to their receptors. And then if we're giving them that partial agonist, the slower car, we could risk putting them into precipitated withdrawal. And so we need to have a conversation with them. In terms of methadone or slow release oral morphine, it's up to 3 days, because at that point, we're going to worry about a lowered tolerance and we're going to worry that their dose might be not one that's very safe for them. Though honestly, in these day and times, if they're using any other additional street-sourced opioid, their tolerance is just fine. And Dr. Mogus will be getting to tolerance in just a moment. Okay, I'm going to pass things off, but I feel a bit like Joy. I'm super excited, right? I'm leaping in the air. This is great. Why aren't we all doing this? And and I know there's some anxieties out there that are like, I thought there was some legislation, and I thought that there was some things the government said that we're not supposed to do. You seem really excited about this, but I'm feeling nervous. So thank you for being here, Dr. Mogus, to address a large elephant in the room.
Okay, lucky me, not a lawyer, get to talk about legislation. So pre-October 2022, I think this is what most of us did. We determined a medication might be indicated to treat a patient, and then we prescribed it. Easy peasy, that's what we learned about in medical school. What happened in October of 2022 is this. So this is the current state of affairs for prescribing opiates for certain indications, and we're going to dig into that a little bit. So in October of 2022, the government came out with this Mental Health Services Protection Regulation, MHSPR, and they also released something they called the Community Protection and Opiate Stewardship Standards, the CPOS standards. There's lots of acronyms here. I've linked it if you're interested in reading the entire document. If you're keen, it's fascinating reading. This slide is from our Arch Medical Lead, Dr. Clausen, and just to say that when this came out and a few months before it came out, there was a heck of a lot of back and forth with the Arch team, with stakeholders. I'm sure some of your leadership here had some discussions with AHS and Addiction and Mental Health to clarify this confusing legislation, which is still causing confusion. I think our concern is primarily for our patients with opiate use disorder and how this is going to affect them. But there's also concern for the prescribers, of the people who are prescribing opiates. And the reason there's concern is because there's fines if you do not follow the act. So the penalties take the form of fines. You can see here I've bolded it's $10,000 for each contravention to a maximum of $100,000. If that's reassuring to you in any way, that $100,000 is the most they can fine you. I don't know about you, but potential financial ruin was not covered in the medical school. It wasn't a benefit of going to medical school. So let's just talk about how we can potentially avoid that. So at its core, this legislation regulates the prescription of opiates for people with a diagnosis of opiate use disorder. They've made up this term, designated narcotic drugs, or DNDs, which they talk about a lot in the legislation, and it's on that flow sheet. And the definition of that is any full agonist opiate medication, except for the ones that Jess talked about, so not methadone or SROM. They do not regulate opiate agonist treatment, and they do not regulate opiates for conditions other than opiate use disorder. So if you are a patient in the community getting 10 tabs of Dilaudid 8 milligrams a day, dispensed monthly, and you come into the hospital, you can get your Dilaudid 8 milligrams as a DND in hospital without any issues. So let's go through this flow sheet. So the first and the top line is pretty straightforward. So if you admit someone with a broken leg, they have osteomyelitis, they have frostbite, they require a DND to treat a medical condition that's not opiate use disorder, then you can give them a DND in hospital. That's fine. Patients on hydromorph content for chronic pain in the community, they come into hospital, give them a DND. That's fine. You're complying with the legislation. Now, the second row here, you can read it, but it says if the patient is currently receiving NTS from a licensed service provider. Now, what the heck is NTS? Another acronym. We'll talk about that. If they are receiving NTS and they're admitted to a hospital, then you can give them DNDs. So what does this mean? So what is NTS? Narcotic Transition Services. This was introduced through this legislation. It's provided only at Licensed Recovery Alberta programs. There is 6 in the province, 1 in Alberta, or 1 in Edmonton, sorry. This is the picture of it. It's downtown on 106th Street. So what do? They give people DNDs, most often hydromorphone, IV, IM, or PO. And this is for folks who have severe opiate use disorder. So they haven't been able to stabilize on any oral therapy. They've been trying multiple different things and it hasn't worked. They can go to this Narcotic Transition Services. They can self-administer injectable opiate agonist treatment, but they have to go to this site, which is a barrier, as you can imagine. This is provided by addiction medicine specialists, and of course, they focus on getting people eventually onto oral agonist therapy as much as that's possible. So how do you know you have an NTS patient? Well, it is actually pretty obvious in Connect Care. I've just copied and pasted this from one of our NTS patients. So they're in Connect Care under a big care coordination note is a note that says, please look at their exceptional care plan if you see one of these folks and you're admitting them. The exceptional care plan has a lot of specific information. If you're admitting them after hours, it has some things on sort of what to do. You can see there they have a phone number. There is a doc on call 7 a.m. to 7 p.m. at NTS, 7 days a week to talk to them. Also, if you look on Netcare, the other clue is that these are the only people in the province that are getting injectable hydromorphone in their PIN list. So you can see there it says injectable OAT. No one else is getting injectable hydromorphone. To comply with the legislation for these NTS inpatients, it's important to know a few things. So you should communicate as soon as you see these folks or as soon as is feasibly possible, contacting their community NTS prescriber. They'll give you a lot of information and guidance, and they're really, really quite helpful because we want to continue. You can imagine if someone's on 100 milligrams of IV hydromorphone twice a day and they come into the hospital, that you're going to want to continue that as fast as possible, or they're going to go into withdrawal. You can prescribe other DNDs as needed for these folks. There's not any restrictions. And the other thing that they talk about is that you should make a discharge plan, which I hope we're doing anyway. But of course, they give it a different name called Transitional Care Treatment Plan. And what that means is basically, please call them before you discharge these folks back to the community. And the reason being, they'll want a prescription sent to their specific pharmacy and they'll coordinate to get their doses. So if you've dosed their IV hydromorphone at 10 a.m. and then you discharge them at noon, they'll say, please send them over so they can dose at, for example, 6 or 5 p.m. at our site, and they don't miss a dose. So just call them. It's actually quite easy to do. We do this quite a lot at Arch. They're really approachable and really, it's quite straightforward. I don't think you're going to see a lot of these folks. They tend to be, they tend to go to the Alex. And I think there's only about 30 in Edmonton. So on the off chance you come across one, they have come here. Kenan has told us they do, just rarely. So that's the second line of this complicated flow sheet. Now, the third row is where things get a bit murky, and I think there's a lot of confusion. So if you have a patient that you think needs a full agonist or a DND, and they require it to treat their opiate use disorder or essentially their opiate withdrawal, but they're not an NTS patient, we're going to go down to the third row at the bottom here. The crux of this is that if they are admitted for an indication other than opiate use disorder, you can give them a DND. So let's talk about that a little bit more. I think it bears repeating that we can use DNDs to treat opiate withdrawal if the patient is admitted for other indications. And that's the most important piece of this. And there's a lot of confusion around this. So let's talk about it. So what is other indications? What in the world does that mean? So the definition, and this is in an FAQ document that I've linked further in the presentation if you're interested in reading it. They've had to make multiple documents to clarify this definition. So a medical or psychiatric condition other than opiate use disorder and withdrawal that would typically require admission, not including the V codes or psychosocial codes. So that's an other indication, according to this legislation. So if you admit someone with opiate withdrawal and an MI, you can use DNDs to stabilize their opiate withdrawal. That's absolutely okay. If you admit someone in opiate withdrawal and they're homeless, that's it. You cannot use DNDs. So because of this confusion, and this is where the link is in the presentation, they have multiple clinical scenarios in this document to try to clarify this, because I think it's confusing, and I can imagine that you probably think it's confusing too. We still get questions about it, and this is 2.5 years after this legislation came out. So just to clarify, and this slide is courtesy of our Arch medical lead, if someone is here with recent or recurrent opiate poisonings only, they can't have a DND to stabilize their opiate withdrawal in hospital. But if they're admitted with an opiate poisoning requiring care. So if they're on a naloxone drip, if you're working them up for aspiration pneumonia, they can get a DND. So you can see why this is confusing. If they're admitted with psychosocial issues only, they cannot have a DND to stabilize their withdrawal. But if they're admitted with failure to thrive, they can have a DND. The other thing I would point out is second from the bottom here, this pre-existing medical, psychiatric, or developmental conditions that in combination with opiate withdrawal warrant admission, that piece is pretty important because a lot of folks have a condition that in isolation wouldn't warrant admission. So in the FAQ document, they mention schizophrenia or FASD. And if that in combination with opiate withdrawal puts them at risk of harm if they were to be discharged, that is okay to use a DND when they're admitted. So there's a bit of a gray area there. All right, so how do we document this stuff so we don't get a $100,000 fine? I have this as a Connect Care smart phrase, this exact wording. And this exact wording is actually in the most recent FAQ document that exists somewhere in the AHS interweb. I actually couldn't access it. It's not publicly linkable, but this specific, please feel free to copy and paste this. And every admission history that I do, I put this on there and I check mark which reason the patient is here and why I'm using a DND for that patient. So please feel free to use that. All right. So I hope this flow sheet is a bit clearer. I'm happy to answer any questions at the end. I think this is still quite confusing for most folks, but let's move on. So I hope we're a bit clearer on who we can use DNDs for in hospital. Let's look at some common scenarios that I see on ARCH that come up with inpatient management of our folks in the hospital. So just to start out, this is a expert opinion slide. I took an informal poll of our docs and NPs at my clinic just to say, what do you consider low, moderate, and high tolerance for folks who are using illicit fentanyl? And this is sort of the average of what we came up with. The reason I put this up is I think it's important to ask someone what they're using. How much, how often, what are they using? And the reason is to get a sense of their tolerance, which of course, a point of fentanyl one day is different from a point of fentanyl later in the same day. So there's not a ton of consistency, but if someone's using 10 points a day of fentanyl, that's different than someone who has a puff every couple days. The reason we want to know that is because if your patient's in withdrawal in the hospital and you've decided you can comply with legislation by giving them a DND, what would you give them? How would you start? And they see a lot at the Alex that people give our folks 1 milligram of hydromorphone or, 0.5 sub-Q every 6 hours. That isn't enough. That isn't enough. Even for someone with low tolerance, this is what I start out with, and this is conservative, okay? So we're using liquid hydromorphone and we're using morphine oral solution. We're not using sub-Q, we're not using IV, we're not using tablets. The reason for that is to reduce the risk of diversion. And the reason we're not using sub-Q or IV is because oral is absorbed slower, so it doesn't reinforce those addiction pathways quite as much as the sub-Q or IV. So you can look here at the doses. We always write, because when Connect Care comes up, I think it says, if you put in hydromorphone, it comes in for pain as a reason to use it. I add cravings and I add withdrawal. Because if the patient asks for a medication and the nurse says, are you in pain? And they say no, I'm having cravings, they might not get it otherwise. So I think that's important. The other thing to write is witness the dosing and don't dose if sedated, which I think is obvious, but I always write it. These doses are conservative. Like I said, I have a very low threshold for going up if someone tells me they think they need more. And if someone tells me they think they need more, I just believe them. These folks live their lives in withdrawal. Every day they're in withdrawal. So they know when they're in withdrawal. You can, if you feel strongly about it, document that there's some objective signs of opiate withdrawal, and I've put them here. You can look at the CAL score, but just believe them. Remember to put IM naloxone orders on the chart, and don't forget about these other things, because we can still use Gravol if they're nauseous, clonidine if they're sweating, and ibuprofen if they're in pain. So what if someone's delirious or they had a seizure? How does that relate to opiate use disorder? Well, fentanyl is cut with all kinds of nasty things, including benzos and some CNS depressants that isn't technically a benzo, like xylazine. Lots of stuff we can't detect is in fentanyl. We think there's designer benzos. So when they come into hospital for heavy daily users and they have abrupt cessation of their street source fentanyl, they can actually go into benzo withdrawal, which we don't always think about if they're not reporting that they're using benzos, because sometimes they don't know that they're using benzos. So if you have someone that you've done a medical workup, they're delirious, they're having seizures, or psychotic, it might be worth doing a fixed taper of benzos. Negative urine drug screen probably isn't going to help you. It takes 3 days to come back. And for the most part, these benzos are not in their urine, but it's something to think about. So what if your patient's overdosed? I'm sure this happens here. It happens at the Alex. We have a supervised consumption site and our patients still overdose in the bathrooms, you know, in their rooms, all over the place, in the cafeteria. And you don't have a supervised consumption site here. So imagine you see this. So the first thing I would do is ask them what happened. Talk to them in a non-judgmental way. Did they use illicit opiates on purpose? Because sometimes people are using meth cut with fentanyl, and they're not actually even intending to use an opiate. If that's the case and they're using meth, I would talk to them about how can we use in a safer way? Can you use with other people? Can you bring a naloxone kit out with you if you're going somewhere else to use? Also, I like to ask patients, what do you think would help you to use less? Because they have suggestions sometimes that you don't think of. So for example, on the ARCH team, we have adult coloring books. We have crossword puzzles. We have Sudoku. And you'd be surprised how often people say, just give me something else to do, because all I'm doing is sitting here staring out the window thinking about using. And it's something as simple as that can reduce their risk. So if they do say that they used opiates on purpose, I would ask, why aren't they using the PRNs that we have for them? And just reminding them again in a non-judgmental way that that's what they're there for. Do they feel judged by the nurses? This happens a lot, even at the Alex, who's had the ARCH team for 10 years, and all the knowledge translation and things we've done on the units, people still feel judged because opiate use disorder is such a stigmatizing illness. If they're not using the DNDs, I'd ask why. Do we need to go up on their PRN or their DND to help with their cravings? If they're on OAT, do we need to go up on that? Should we be treating their opiate use disorder a bit more aggressively? And you know, when you start methadone, you can only go up every 2 or 3 days, and you have to start out at a pretty low dose. So in the first little bit, they're going to need those PRNs to deal with their withdrawal, because we can't replace their opiate tolerance with OAT. And of course, how can we support them to use in a safer way, well admitted? So what if your patient's sedated? This happens a lot as well. The first thing I would say is please check that they're actually sedated, because I don't know how many times I've gone out to the units and the nurses have said, oh, I couldn't give that PRN because the patient was sedated. And I walk into the room 10 minutes after and I say their name and they leap up in bed and say, I'm in pain, why can't they give me the medication? Or they're sleeping. If you can wake them up and they can talk to you, they are not sedated. So please check that first. The other thing would be, sorry, is there a medical reason? For folks on morphine, we've had people on 800 milligrams of Acadian that go into acute renal failure. Well, the metabolites are building up. That's why they're sedated. Or someone that's on methadone that we've started fluconazole, and that increases the methadone concentration, or they have meningitis or some other medical reason, which you're all very able to figure out. Are they using illicit drugs? If that's the case, talk to them as in the previous slide. If we think the PRNs are causing the sedation, it's easy enough to reduce them, increase the interval between them. I usually give the nurses an interval. So if I'm dosing, it'll say hydromorphone 4 to 8. And you can talk to the nurses about maybe dosing them lower on that interval to try if they've been getting the 8 milligrams. The OAT doses can be reduced, and I would do that only if there's more persistent sedation, but please do so in consultation with an expert. And the reason Jess mentioned was if you have a a cup full of opiate tolerance and you're dumping out a bunch of it, you need to replace it with something which is tricky to do if someone's on methadone or buprenorphine with PRNs. So please talk to an expert. This happens a lot often too. So someone's post-op or they have acute pain issues. What do we do? I heard you have an excellent acute pain service here. So get them involved early if someone's going to the operating room for their frostbite or for whatever else. They come out on lidocaine or ketamine infusions, which spare opiates and work exceptionally well for these folks. So get them involved early. The other thing I would say is that people with opiate use disorder and people on buprenorphine or Suboxone generally need higher PRN opiate doses. And that's okay, that's expected. You know, believe them if they say they're in pain, because they know. The other thing to consider is that someone coming in on a stable dose of methadone is different from the person coming in using illicit fentanyl. So the person coming in using a bunch of illicit fentanyl is probably going to need higher PRN doses than the person on a stable dose of methadone. Those are two different people. Don't forget about the other things we can do. We're not just going to treat their pain with opiates. We have all kinds of other things. Ketamine is one that I think we don't think about enough. Works really, really great for dressing changes. All right, I'm gonna pass it back to Jess for discharge planning.
Feel like the mic didn't pick up your heavy breathing like it did mine, so I'm gonna try this handy dandy clip it to my shirt thing before I like put the little microphone inside my mouth again. Okay, so who's ready to get out of here? This guy sure is. But we probably shouldn't start discharge planning when the wheels are off the tarmac, right? We should really start our discharge planning when we're just even thinking about leaving the gate. So that's what we're going to talk about. A big thing we hear, but I can't prescribe methadone. So we get our 3 p.m. Friday phone call, your patient's being discharged from hospital, and we need you to send their methadone prescription over because the admitting doc can't prescribe methadone. Well, this is taken from the CPSA standards. You absolutely can. So if a patient is either admitted to hospital or incarcerated like I was years ago, just kidding, you can absolutely provide them their methadone or their SROM. This does not apply to buprenorphine naloxone. You can make it rain buprenorphine naloxone. You don't need a triplicate for buprenorphine naloxone. Not that you should, but I mean, some of us believe that we should just have a bowl of it on every corner if people want it. But anyways, but you can absolutely provide them their methadone and their SROM for the duration of their stay and for 120 hours, not 121, but for 120 hours after they leave, about 5 days. So if it's Friday and you can't get a hold of their provider and community, you can absolutely give them meds to get through the weekend at the very least. This should be prescribed daily and witnessed, so we're not just giving them 5 little vials of methadone in their pocket or their fanny pack to go. And again, the standards recommend that you're consulting with their current prescriber or their appropriate delegate before making any changes to their dose and collaborating with them, or any other members that are involved to help make that transition smooth for them. Okay, so how will you know if they have a community OAT provider? Like you're shocked to see your face up there. I asked you if I could use that fabulous picture. First of all, you're going to ask the patient, hey, does somebody provide you methadone or SROM or Cadian or buprenorphine naloxone in community? You can check NetCare for a recent OAT prescription, or you can get help from your team to coordinate this. And you don't have an ARCH team, and we know that that's sorely needed. And gosh, do we wish we were making some decisions out there? I'm sure we all do many times a day, but you have an incredible person that is on your team. Her name's Kinnan Ross. She's sitting right over here with some fabulous glasses on. Unfortunately, if you're on Zoom, you can just look at this beautiful, fabulous glassed photo. Kinnan's an incredible person, but a clinical nurse court educator here at the hospital who's doing really awesome work as one person. I mean, we've talked about how teams are like so necessary for this work. But you've got Kinnan, and she's working her buns off. She's doing educational sessions for nurses and anyone else that wants to attend. So if you're listening to us today, and you're like, boy, oh boy, I wish I could learn more, Kinnan's got you covered. She's also someone that you can consult if you have a patient admitted to your service that has opioid use disorder and you're saying things are not going well, or maybe even if they are, but you want some added supports. Kinnan will educate your team, will talk to your nurses about how to interact with that person, about how to assess for withdrawal using a COWS scale, about how to look up if they have a community OAT provider. All of these different things so that that transition can go smoothly. And I think I can speak for Kinnan to say involve her as soon as you want to. Really, it doesn't need to be, again, when we're rolling up to the tarmac. Okay, what if the patient does not have a community provider? This is hugely important, and this happens all the time. This is a link that's embedded in the ED buprenorphine naloxone order set, and it's going to take you to a table that has various clinics that are available. You're like, I don't have time to like look up a clinic or figure out which one's closer. Don't worry. You have within Connect Care an ambulatory referral to Addictions Mental Health. The important thing that you have to make sure you enter is that you're referring them to the Edmonton 108th Street Addictions Mental Health Opioid ODAC, basically. Watch me forget the last 4 letters of that acronym. Um, but this can happen as early as possible and should happen as early as possible. Because if we wait until discharge day and this person doesn't have a phone, why did we even do this? So they will triage this patient and they will come to the unit to talk to them about discharge planning face to face to figure out where they want to go, how we can get them to this outpatient appointment before they leave the hospital. And that's what we're trying to do, is do anything we can do before they leave the hospital. Another hugely important step in managing opioid use disorder is poisoning and overdose prevention. We do that by making sure people have naloxone kits. There's a couple other resources that people may not be familiar with. Unfortunately, they do require a bit of privilege. They require a phone, but there's a national overdose response service phone line where patients can phone in, and it's used like a virtual supervised consumption site. So you give your location, you give permission for EMS to be dispatched to you if you become unresponsive, and then you use while on the phone with this service. This was put together with many incredible people, but Dr. Monty Ghosh is one of them, and they have a fantastic report that detailed how many lives were saved with this right here. In Alberta, we like to just up the privilege just a bit. I don't know if we've noticed that. It's the oil, I think. But if you have a smartphone that has apps, we've got the digital overdose response app that people can use, which is a very similar thing. It's going to key you to touch a timer to say, yep, I'm still here, yep, I'm still here. And if at any point you're not touching that timer saying, yep, I'm still here, a very loud alarm will sound to say, whoa, 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 are you still there? And if you're not responding to that loud alarm, then you've given permission through the app to have EMS dispatched to you at the location that you provided. So yeah, as we see what happens with all of our supervised consumption sites, we still do have some access to safe use. And particularly keep in mind that if a patient is smoking their drugs, which is what a recent inner city survey of about 499 individuals who use drugs found, about 94% of those people were smoking their drugs, they cannot smoke in a supervised consumption site. So assuming that there are safe places to use that they are choosing not to access is not the case for 94% of those people. Okay. It's really hard to get a group picture of us, so we've only got a few there. Unfortunately, the beautiful Dr. Mogus is not in those, but we've got all of our providers' names for you here. If you see these names on Netcare, do not hesitate to pick up the phone and call us at the number that we gave you. If you see that phone number on their Netcare, please do not hesitate to pick up the phone and call us. We love to talk to you about our patients that we have known for many years, that we know very, very well. And I think that they like it too. So we would very much love to talk with you about them. All right, thank you so much for taking the time to listen to us today, to talk about how we can share care with our patients, and we would love to entertain any questions at this point.
I'm going to take the privilege of asking the first. That's okay.
I wonder if you need to talk in the microphone just for our virtual attendees, either into our cute fuzzy
Sure.
box, or you can, oh, just kidding. Are you okay if I point this at you?
Sure.
won't be able
You know, one of the challenges is route of administration. And I wonder if you can give advice when, you know, you've got a sick patient who just does not want the oral route. Can you give some advice?
Absolutely, she can.
Thank you. I mean, I think for really sick folks that can't take medications orally, we do sub-Q for a few days. But if you're clear on expectation that this is for 2 days, and then we're going to switch you to oral, I think people are pretty reasonable. The other thing I say is that this is all we can prescribe you. This is what we can do. These are your options. And sub-Q, unfortunately, is not one of them. We don't usually start people on sub-Q because then it's hard to get them off. So if you don't do it in the first place and Emerge hasn't done it in the first place, then I wouldn't recommend we start. And that does make it easier, but having clear expectations, sometimes you can work with the patient for a day or two. I think it's reasonable, but past that, it's just not. That's what just worked for us.
Yeah, so in emergency really is where the challenges lie, right?
sometimes.
Yeah.
Yeah, less often at the Alex though. I don't know what they're doing with their group, but they don't do it a lot at the Alex.
Um, okay, I'm just gonna read a question here. Why is NTS using IV hydromorph given it acts so quickly and re-emphasizes addiction?
So the IV hydromorph is for a very small subset of patients who haven't stabilized on any other therapy. The idea with the IV hydromorph is that it's not, I think, meant to be a long-term treatment. It's meant to keep people alive long enough so that we can connect them to other services, so that we can get them housed, so they can do some counseling. And so, like I put in my slide, the goal is to put them to the oral agonist therapy, but for some people it hasn't worked. And we've tried and we've tried and we've tried. And so this is sort of a last option for folks that have failed other types of OAT.
Other questions, either in the room or, yeah, Peter.
Just a theoretical question. Is there sort of a minimum dose of Suboxone that you would consider to be protective or overdose?
16 milligrams, I think, is what's been borne out in studies.
Okay,
16 milligrams of the buprenorphine piece. When we talk about Suboxone dose, we talk about the buprenorphine part.
okay.
Yeah.
Great. Yeah, thank
The
you.
other thing I think that wasn't mentioned about Suboxone is that a lot of people think that it's the naloxone portion that's causing the precipitated withdrawal. If you're taking the Suboxone sublingually, the naloxone has a negligible effect. It's that partial agonist high affinity that's putting people in precipitated withdrawal. The naloxone is there to reduce diversion risk. So people aren't injecting Suboxone because all they get is the naloxone part if they try and inject it.
Oh, hi, that's it, yellow box. So when you give Suboxone sublingually, the naloxone doesn't really absorb. So it's when you crush it and get it wet and try to inject it that naloxone becomes active. So people get really thrown off by Suboxone because it's got the two values on it, because there are two drugs in that tablet. But really the focus should be on the first number, which is the buprenorphine component. And then the naloxone piece is, as Dr. Moga said, really not part of the equation.
Can I just ask a follow-up question on?
Just wait,
that?
Peter.
Great. If I could just ask a follow-up question on that point. I was presented by somebody, some trainee about, the sort of separate issue, sorry, but this whole question of oral naloxone, whether there's any use to that to like opioid induced related constipation. No.
Oh,
like,
for
no-
constipation.
No benefit whatsoever.
Yes, absolutely.
Yeah.
Yeah, it works for opiate-induced constipation,
It
for
does,
sure.
eh?
Yeah.
Oral naloxone.
Oral naloxone.
Okay.
Mhm. Yeah, doses of like 5 to 15, 20 milligrams BID, TID for opiate-induced constipation. And that's about the other things haven't worked. It is available. It just needs to be compounded in the community. And it's not also on formulary in hospital.
Okay.
So it's tricky to get. They'd have to get it from a community pharmacy in hospital.
Thank you.
Mhm.
Nice trick. There's a question online that is tricky. A person who would like to return to employment where they cannot be taking opioids, such as an equipment operator. Can you suggest a transition to have them weaned off completely?
You want to take this?
Yep.
I mean, this is a huge barrier, right? There's a major gap there. I actually have done speaking for the Alberta Construction Association regarding this also, that the misconception that having naloxone on site is a bit of a gateway drug to allow people to use. To that I responded, do you not have an EpiPen? Is an EpiPen, just letting people freely take peanuts all the time and going into anaphylaxis? But so I mean, that is one of the major problems that our patients face, a massive barrier. And what we have for evidence about mortality is actually in that exact group when we look at withdrawal management. So we see withdrawal management in detox. We're helping people withdraw. When people leave detox on no form of opiate agonist therapy, they had about a 3 to billion time risk increase of a poisoning death. When we see people leave corrections, they are at a massive increased risk of overdose death. And so this these patients, employers are putting their lives at risk when they could very easily be managed on opiate agonist therapy. The same goes for treatment centers in the province that will not allow patients to attend their treatment centers on opiate agonist therapy. And those treatment centers should not be receiving a cent of public funding. So, yeah, what I will say is that, what I will say is that this is a massive barrier. I would be talking with my patient, and unfortunately, many people are forced into withdrawal treatment for a variety of reasons, and it's really scary. And so then what I've heard many people do, again, my massive girl crush, Christy Sutherland, will send people to treatment centers with a pocket of Suboxone and say, make sure you put this somewhere that they can't find it. Because if you're in treatment and you're going to use, and the only thing you have access to is something that will kill you, please use this first. I would be finding out if there was some sort of loophole, like maybe those urine drug screens didn't check for buprenorphine, because there's absolutely no reason that a person couldn't safely operate any type of machinery while on buprenorphine. We give infinitely more dangerous medications to people and we allow them to drive. So I don't know if you have anything to add to that.
Anyone with chronic pain also
Yeah.
is allowed to operate a machine on a hydromorph content dose of 100 milligrams twice a day, you know, for some chronic pain people, folks with chronic pain. So I think that's a good point. Yeah.
Takes a massive culture shift, right? Yeah, which thank you to your program is helping to move forward. Really helpful. I know it's long overdue, this talk, so we really appreciate you coming and helping to make a lot of things a lot clearer. There are a lot of resources. Thank you for pointing those out, both in Connect Care as well as in, you know, various places. So this will be recorded and the slides will be made available for folks, because a lot of us do look after inpatients, not just opioid use disorder patients specifically, but even those patients with OUD that come in with their MIs or their strokes or whatever. So really important topic. On behalf of the department, I know we've got people chomping at the bits outside. So thank you so much. And we look forward to seeing you again.